Now, we will move into today's featured topic presented by Dr. Subramanian, Wellness in PD. Dr. Evidente will be joining Dr. Subramanian after her presentation. Dr. Subramanian, please proceed.
Thank you so much for having me. It's a great opportunity to see everyone out here and to share something that I'm very passionate about to a population of folks that I love. And it sounds like it's a very international crew. So thank you for the opportunity. So without further ado, I'm going to share my screen here and hopefully you guys can see this. Can everyone see that?
Perfect, yes.
Okay, so I'm actually going to share a screen of this talk, and I just had modified it a little bit from a talk that I just gave at the Movement Disorder Society meeting, and hot off the press, and wanted to sort of allow you to see sort of what I presented to some of our colleagues who are neurologists and other sort of allied health professionals who are taking care of you in this space. And I'm actually coming to you from actually in Arizona, not too far from where Dr. Evidente is, and I'm at the Parkinson Study Group meeting. So much of this is very new and very exciting, and I think your healthcare providers are starting to, I think, understand a little bit about this field that I've been sort of cheerleading around. So I'd love to sort of bring you up to speed and teach you a little bit about wellness in Parkinson's disease. So classically, Parkinson's disease is a diagnosis that has been taught by these drawings. And just to kind of give you a sense of the doctors that are seeing you and what their image of Parkinson's is largely around these sorts of pictures of white men who are older at various stages of the disease. This comes from an atlas called Netter drawings. And these are sort of the images in which we as clinicians worldwide have learned about Parkinson's, and it's largely been sort of a motor sort of disease that we've thought about. And we educate our medical students with this mnemonic. We teach them about tremor, rigidity, akinesia. So these are the cardinal symptoms, or otherwise known as tremor. So that sort of movement that you see that's we see sometimes in one side of the body at the beginning of Parkinson's disease, rigidity, which is sort of this stiffness that patients describe, and then akinesia, or slowness of movement, and then eventually developing things around gait. And this is the mnemonic that we teach our students. We teach them with these sort of pictures, and largely, you know, focus on this motor sort of progression of disease. But this is just one aspect of Parkinson's disease that those of you who are living with this, those of you who are caring about patients or caregivers of people who are living with Parkinson's, and those of us who are healthcare providers who work in this space know that it is just the tip of the iceberg to think about the motor complex. And really, it's much more under the surface and hidden in sort of behind the face of Parkinson's disease. Behind the motor aspects lies a huge non-motor burden, including a number of non-motor symptoms, things like the sense of smell, constipation, things like sleep disorders. And there's also a huge amount of mental health burden that many of our patients are bearing. And it's really these non-motor issues and the mental health burden that affects quality of life much more actually than the motor symptoms of Parkinson's in many of our patients. And so again, when we're educating people, we need to be teaching them that Parkinson's is not just a motor disorder, and it can really affect so much more. And when we think about the mental health issues in Parkinson's, because we don't teach doctors or healthcare providers about the fact that Parkinson's is not just a motor disease, often doctors don't ask about these problems in the patients that they are taking care of. And because I, as a movement disorder doctor, generally is under the field of neurology, I am a movement disorder clinician who takes care of motor disease issues. Many of patients don't realize that Parkinson's, in fact, involve a huge amount of mental health issues in many types of patients, and they then don't describe or complain about these problems to me. So this is part of why there's a huge barrier to getting mental health access, is that we have a lack of disease awareness, and then there's a scarcity of mental health providers as well. And so these are two reasons that a lot of our patients with Parkinson's don't get access to mental health issues and help. But there's also a number of other problems that come as part of the current environment. And one of those issues is that caregivers are often burnt out and they themselves may be dealing with their own mental health struggles. We have this pandemic that's ongoing that's led to social isolation. Many people have lost loved ones during the pandemic and are grieving, and this has contributed to the mental health problems that we are seeing. Additionally, there is a stigma that is associated with Parkinson's disease itself. So many patients who are living with Parkinson's, they feel some shame, sometimes feel embarrassed to tell their loved ones about this problem. And then you add on these mental health issues, and there's a stigma around mental health issues in general as well in our populations. And so people just don't seek out care because they're embarrassed to talk about the sorts of things that are included. And then what COVID-19 has taught us is that we haven't been giving care to many populations at risk in an equitable way. And so there's really disparities of care. So patients who are living with this disease who may be Latinx origin or Black, women tend to not get good care in these regards. And also depending on where you live in the world, sometimes we have very little access to mental health issues. For example, in parts of Asia and Africa, there's very few movement neurologists that are trained. There's very few psychiatrists that know about these issues. And so really, we have a very limited pool of folks that are able to give this sort of care in general. And so when we're talking about mental health issues, just to let you know, many people with Parkinson's, even before they ever get diagnosed with Parkinson's and the motor symptoms, are already dealing with certain types of issues that are part and parcel of the disease. So when we think about the sort of trajectory of Parkinson's disease, by the time people present in my office with motor symptoms, as I mentioned, there are a number of what we call prodromal symptoms of Parkinson's that can predate motor symptoms of Parkinson's by sometimes 10 or even 20 years even. And so when you think about, what are the types of things that you may have had before you might have had onset of tremor or before you started having motor symptoms, many patients describe a change in their sense of smell for sometimes 10, 15, 20 years. And that often results in a change in their sense of taste. Sometimes there's also issues with their sleep changing, and patients will describe, or the loved ones of people who are in their bed, the bed partners of patients living with Parkinson's will describe sometimes acting out dreams or yelling out in sleep. And these sorts of things may happen 15 to 20 years before people develop motor symptoms of Parkinson's. And as I mentioned, there can be issues already even predating motor symptoms, including depression and anxiety that can be seen in Parkinson's patients before they ever develop motor symptoms. And then if you follow this motor timeline along, there's a progression of disease that I showed in those pictures where people may have stiffness, slowness, and tremor, and eventually developing balance issues and things like that. But there's also a host of non-motor issues that include things like cognitive issues, sleep dysfunction. Some people may develop seeing things that aren't there, or hallucinations that might develop. And so really, as we sort of follow this timeline through the course of disease, it's not just motor worsening, like in this top line, but really a host of non-motor issues throughout the trajectory of disease. So I think we've done a good job, I think, as Parkinson's doctors, focusing largely on motor symptoms and treating these issues. But over time, we can develop increasing issues in non-motor realms as well. And unfortunately, we don't have great therapies for a lot of these non-motor issues that are well tolerated in Parkinson's disease. And so I want to propose to you not just sort of an approach to Parkinson's where we give something like replacing dopamine in the formulations of Cinemat, or depending on where in the world you live, carbidopa, levodopa preparations. We have found ways to administer this through pumps and things like that, or deep brain surgeries, but really thinking outside the box in terms of a little bit of a novel way of looking at the approach to a Parkinson's patient. So the title of my talk is on wellness in Parkinson's disease. And so what wellness is not the opposite of illness. I want to teach you a little bit about this concept. So the definition of wellness, as I like to think about it, is the active pursuit of activities, choices, and lifestyles that lead to a state of holistic health. And so really the concept is that the person living with disease has some control over their outcome, that they have the ability to choose choices every day and incorporate them into their lifestyle. And that when we think about health, that it's not just the absence of a physical symptom, but really this more holistic concept, including lifestyle, mental and spiritual well-being, and including the environment as well. And so when we think about the paradigm that I wrote about in those bubbles about the archaic paradigm of the medical model, really thinking outside of that regular Western paradigm of the medical paradigm of care, where a patient comes in, they complain about a symptom, and my job is as a doctor to correct that. And we episodically see that patient in my office every 6 months. And I, as the clinician, am responsible. It's very compartmentalized, where the care and the health care is being delivered in an office setting where we're correcting symptoms. I want you to think about this care a little bit differently and think about more of this wellness paradigm in which we're shifting the sort of treatments into more of the sort of regular daily life, and that the person living with the disease is part of the process of getting better, and that the control of their outcomes is in their control to some degree, and that it's really the individual living with the problem that is responsible for some part of their healthcare. It's integrated into their daily life in this more holistic, preventative way, and that I'm not just trying to improve a symptom, but really helping the person live and thrive with a better state of well-being overall. And so I work in the VA. As the introduction said, I am a VA doctor. I run one of our 6 centers of excellence in the country, taking care of veterans with Parkinson's disease. I take care of the Southwest region. And so my catchment area is all the way out from California and the coast of California out to all the way to New Mexico. So that includes Arizona. And it really, the VA has been kind of able to, I think, incorporate, because of the way we have quite a closed system of care, and I am salaried, and we are able to care for patients a little bit outside the usual ways of having to bill an insurance company for certain types of care. We have been able to use this paradigm of what we call the VA whole health model. And so this model includes the patient in the middle, and then we have this sort of bubbles around them in which we have sort of different lifestyle choices. And I'll be teaching you a little bit about some of these lifestyle choices for Parkinson's patients. And then we have not just treatment or conventional therapies, but really this preventative complementary approach to care. And the patient, the person living with the disease, is really not just alone, but surrounded by the people that are in their various circles of interaction, and they're living in the community in which they live. And so we're really thinking more about this more holistic way of addressing health. And so thinking about that and catering it to a Parkinson's patient, we have these various bubbles in which we have the way to affect lifestyle changes. And I'm going to teach you a little bit about a few of these, and then spend a little bit more time on some of them, especially revolving around social connection, because that is a focus of my research interest. But no sort of care for the Parkinson's patient can be done just thinking about the Parkinson's symptoms. It's important to think about living optimally with optimized general health as well. And so when we're looking at Parkinson's patients, it's important to think about their bone health, their gut health, thinking about constipation, the gut microbiome a little bit, thinking about vision and dental. What we're realizing is that vision issues, dental issues, hearing issues can all contribute actually quite remarkably to how healthy people are. If we have poor vision or poor hearing, we are at a much higher likelihood to get cognitive disease. If you have poor dental health, you're actually at a higher likelihood to get cardiovascular disease. And so optimizing many of these, including even things like sexual health and general health, can actually be quite important for how well people are living. And then we wrote this and put these diagrams in a chapter on sexual health and wellness in Parkinson's, in a book on sexual health and non-motor issues in Parkinson's that just came out. But we put this figure in looking at wellness and all the things that can contribute to wellness in Parkinson's disease. And so many of you know that we believe as clinicians that exercise is like medicine. And so it's important to try to move your body and exercise every day. If you can, 30 minutes a day, at least 5 days a week, is somewhat of an exercise prescription that we give patients as almost as if it is medicine. The diet is important in Parkinson's disease. So diet that is largely whole food, plant-based. Mediterranean diet is like largely the one that we recommend. And good hydration is also key because many patients with Parkinson's are at risk for dropping their blood pressure or getting dehydrated. So drinking lots of water and lots of fresh fruits and vegetables if you can get it. Sleep is very important in a number of neurodegenerative diseases. Parkinson's disease patients do much better when they get a good night's sleep, as do all of us. And so 8 hours of consolidated sleep is optimal. As I mentioned, I have an interest in mind-body approaches, and I'll spend a slide or two on that, as well as this bubble here. We'll also be focusing on social connection. And then no wellness prescription is beneficial if it doesn't meet the patient where they are, because I can come up with all kinds of fancy things that may be studied and prescribed historically that have worked in that population that we've served, which is a white male patient population that is affluent men that are married, whose wives drive them to appointments. And we've done a very good job in Parkinson's disease of taking care of many of these types of patients in that niche population. But the populations that we haven't been serving well don't look like that. And so if I, as somebody who looks like me, walks into an office as a younger woman of color, and complain of symptoms that are classic for Parkinson's, often we are not diagnosing me and my demographic accurately. And so many of the times we don't diagnose patients who look different than those drawings I showed you in good time. And then also the types of treatments that we give are often not accessible to these different types of patient populations. So I think we have to think about how the cultural context affects people and their state of health. And so it's important to think about, what means, what are the components of health to the individual person? And for example, for the First Nations, which is a tribe of Indigenous folks living in the United States, to these, the First Nations tribes, for them, health includes their ancestors, the wisdom of their ancestors. It also involves things like respect and responsibility to the land and their families. It includes the other nations. And so it would be very hard for me to come up with a wellness prescription if I did not include these sorts of things that are important to this type of people. And so when we think about you as the person, it's very important to think about culturally competent, enabled care for the person that's sitting in front of me. And I think we haven't done a good enough job of thinking about this when we've been thinking about how to treat Parkinson's patients in general. And so for many of my patients, it's important for me to understand where they live in the world, what their race and ethnicity is. I mean, it's very different health for somebody who might be a young Black person, a Black woman who may be a lesbian, may be different than the care of a white affluent man. It might be very different to be a person living in the Philippines with access to certain types of care. And if their religious beliefs are a certain way, all of these things, language barriers, all these things can affect how we deliver care. What we're realizing in the pandemic is that we have been able to serve a certain fraction of patients living with many disease states, but we've really not been able to deliver care equitably to all people living with this disease. And so socioeconomic status is hugely important. And also in this day and age, since so many things are being done with virtual modalities, being able to access digital devices, to be able to get on a meeting like this through Zoom technology is really amazing. But we have to think about those people who are not served with this type of technology. I cannot do virtual visits with a significant percentage of my patients because they don't own a smartphone, they can't afford a computer or device, they don't have access to the internet since they live too rurally, or they may not be technologically savvy. Even if they can buy these devices, they don't know how to use them and connect. And so we really have to think about how to serve all patients living with Parkinson's in a better way. So as part of my sort of exploration of who's not getting good care, I ended up writing this paper just as an example of one group that has not been getting good care. And we ended up publishing this paper in the Movement Disorders Journal, which is the main journal of our Movement Disorders Society. And we put in a couple of figures that were rather novel. And so just to highlight some things that have not been thought about in a population that is significant, for example, women make up at least about 40% of Parkinson's patients worldwide. And in some parts of the world, even though women get Parkinson's less often in the United States, for example, or European nations, in Asia, the ratio of men to women is actually more even. And there are just as many women in some parts of Japan, for example, that have Parkinson's than men who get it. So it is not that rare to have a woman, and a woman of color who's younger, to be presenting with symptoms. And as I mentioned, often these patients are not being diagnosed accurately. Many women feel that their disease has actually, the diagnosis has been delayed sometimes by 5 or 10 years. And then when they are getting treatment, many of the times we are not thinking about things like hormones and its effects on Parkinson's symptoms. So many women who are younger feel that hormonal cycles, when they are going to enter the week before their period, their symptoms worsen. There's not enough information about women who are trying to get pregnant or are pregnant with Parkinson's disease. The perimenopausal time period, so going into menopause, often women feel that they get worse. There's a lot of unanswered questions about hormone replacement therapy in these populations. And there's various sorts of time frames in which women act as caregivers to different sorts of people in their lives. And because of this caregiving, they're spending so much time caregiving for other people, perhaps their husbands, perhaps children, perhaps their in-laws, that they often tend to not seek care themselves and don't get involved with clinical trials as well. And so we're really discounting a large number of patients in terms of who we're treating well and also who we're studying. And when we don't study enough people in the world who are getting Parkinson's disease, including racial minorities, women, younger patients, we aren't getting the full concept of what this disease is about. And so then we don't know how to treat it well in these populations, but it also can help our understanding when we expand genetics into these other populations of what the real mechanisms of how people get Parkinson's, who gets Parkinson's, so we can then help cure Parkinson's for all people living with Parkinson's disease. So it is important to care about every single person on the planet living with Parkinson's, because it will inform us about how to find a cure and how to treat this disease better in all populations. So I just urge you to sort of think about this and learn more about how to get involved. And if you are a woman living with Parkinson's or any of these sort of racial minorities, I think it is so important for you to try to get involved and get involved, not just with advocating for yourselves, having your voices heard, but also in research, because we need everyone to participate so that we can move the needle. So a few minutes ago, you heard about the fact that I'm boarded in integrative medicine. And just so you have a sense of what integrative medicine is, it's really this borderland between standard Western medical approaches. And I went to medical school in Toronto and trained as a Western trained movement disorder neurologist with fellowship training as a neurologist from a Western institution. But along the way, I became quite interested in outside of the box approaches. I had my own health struggles. I became quite burnt out with having children and being a neurologist early in my career. So I ended up becoming quite interested in yoga and mindfulness for my own health and my own wellness. And really from that space, I started to get quite interested in how I could use some of these concepts to help Parkinson's patients. And so I did a deeper dive. I've gotten a lot of training now in some of these areas and have been participating in some fellowships recently that study this. And so it's been kind of a great ability to marry some of the Western medical sort of approaches with these sort of out of the box Eastern approaches, things like Ayurveda, traditional Chinese medicine, mind-body approaches to really help sort of approach Parkinson's patients with a more holistic sort of lifestyle-oriented approach. And I think it marries rather well with this World Health Organization's definition of health, which was defined in the 1940s as health is a state of complete physical, mental, and social well-being, and not merely just the absence of disease or infirmity. And so I think we've sort of, unfortunately, in the last 80 years, strayed away from this definition. And I think that integrative medicine is something that many clinicians are increasingly interested in. I gave this interview with Catherine Lefevre for Medscape Neurology, Medscape in general, and this was the most watched program of all of Medscape offerings in 2021 by neurologists. And so many of your providers are actually quite interested in some of this arena. And so, I would definitely urge you to speak to them about, some of what we're talking about today, because I think people are hungry to learn and are maybe more open-minded than you'd think about out of the box kind of approaches. So I showed you those bubbles. We talked a little bit about exercise and diet and sleep. And so one of these sort of approaches is to, in terms of wellness, is understanding sort of defining your goal of care as a patient. So it's important in that discussion to find out what brings you joy and meaning. And when I give these talks, I sometimes even give these types of talks to healthcare providers, and I ask people to sort of think about really what it is that defines health to them, what brings them the most joy and meaning. And often people have really, unfortunately, forgotten about what brings them joy. And so I urge you, while I'm talking, to think about that. Is it spending time with your grandchildren? Is it traveling? Is it enjoying dancing with maybe your loved one? What really brings you joy? And try to bring more of that. Because I think, we as doctors are not serving you well if we don't ask you these sorts of questions and help understand, what are the answers to this, and then try to help you with your quality of life and to bring more joy and meaning into your daily life. So another aspect of wellness is sort of this concept of mind-body approaches. And as you know, I've done some yoga teacher training. I've done some mindfulness training. And I think some of these words are very scary to many of our patients. They really find that, they can't see themselves sitting on a yoga mat or sitting on a cushion to try to meditate. And they really find this whole concept of mind-body approaches rather inaccessible. But I think that many of you are actually doing some of these approaches in your daily life and you just don't realize it. So really what we're trying to get people to do is disconnect from their sort of devices, get off their computers, get off their phone screens, and really think about these sort of approaches that allow them to get sort of into sort of more of a reflective, contemplative space. And so some of these sort of activities include things like prayer, for example, things like singing, dancing, playing music, doing art. When you get in the flow state of some of this, it can actually be very, very, therapeutic in the mind-body space. Even getting out in nature and connecting with perhaps plants in your garden, or getting out for a hike and getting around trees, maybe looking up at the night sky, gathering around a fire. Many of these things that we have gravitated to, in tribal sort of times in the past are really actually very therapeutic in these regards. There's also ways that we can do journaling, writing, things like that can kind of get us into these spaces, and even simple things like breath work. Sometimes these are actually very powerful as well. Taichi, if it's accessible to you. So all of these things count. And I think that even when we talk about yoga, many people think that they sort of envision something like a ballerina wearing, a young woman who's very sort of limber or flexible, doing contorted poses. But really, this is one of my yoga mentors, and this is Richard Rosen. He has done amazing sort of teaching in breath work or pranayama. He's written books on the yoga of breath, and he's done some really remarkable sorts of things in the space. And he's an older patient, and he actually has been living with Parkinson's now for about 15 to 20 years. He's in his late 60s, and he's a masterful yoga teacher. Matthew Sanford is actually a yoga teacher who was paralyzed and is in a wheelchair since the age of 15. And he's really gotten tremendous benefit from yoga as well. And he's somebody that I've been recording some videos with for veterans with Parkinson's and non-Parkinson's veterans as well. And really, I think if you sort of look out there, there's tremendous numbers of folks that are really amazing teachers in a lot of these spaces that really would blow your mind as to who they're teaching and how accessible some of these practices can be. The reason I like yoga as not just an exercise per se, or just a mind-body practice, but it marries these two, is that yoga in essence has poses that can help with flexibility. Some of the poses, if you do them in a certain rate, can get you some cardio as well. It can work on balance. Parts of yoga can tap into breath work, and really marrying breathing, meditation, and movement is really what yoga is in essence. And then it also has a meditative component. And so there's a lot of this contemplative sort of reflection on the body and the mind, and can be very powerful. So I think yoga is something that I personally think is really magical for Parkinson's patients. There's some early studies now that are showing the benefits of yoga and meditation for anxiety and depression. So some of these non-motor and mental health issues in Parkinson's. There's also been some studies on Tai Chi in Parkinson's patients, and they've shown some benefits in both the motor as well as a little bit in the non-motor realms as well. And so I think there are a growing body of literature on evidence looking at these things. There's also growing bodies of evidence looking at diet, exercise. So many of these things are starting to amass more and more studies and benefits. And so I decided this year to work with the New York Zen Center in what we call a contemplative medicine fellowship. And what this is a deep dive for 30 colleagues of mine. And one is actually an internal medicine doctor living in the Philippines who joins us. It's an international crew. And we are looking at how mindfulness, meditation, and yoga, the principles of this can help us with approaches for our patients, as well as each other as healthcare providers, because many of us have had our own burnout, our own mental health struggles, our own sense of isolation during the pandemic. And I think a lot of the principles of this can help not just our patients, but ourselves and each other as healthcare providers. And so I'm about 9 months into this fellowship and have learned a lot. So switching gears a little bit to the focus of my talk now with regards to social connection, I wanted to teach you a little bit about this field of loneliness and Parkinson's, and how important it is to be socially connected. So we wrote this paper that was published in the Nature Parkinson's Journal in 2020. And this paper was entitled "A Synergy of Pandemics: Social Isolation is Associated with Worsened Parkinson's Severity and Quality of Life." And what we did for this paper, I ended up collaborating with a colleague of mine, Lori Mishley, who is a naturopath who's based out of Bastyr. And we were trying to look at what variables were modifiable for Parkinson's patients. So what are the types of things that people living with Parkinson's can do to change the outcome and improve their quality of life in their daily lives? And so we went into this with a sense that there is a known literature of how social isolation affects health. And we realized through this literature that social connection is a basic human need, just like food, water, and shelter, and that we have an increased need for social connection as we age, and that social isolation is a risk factor for a number of health outcomes that are poor in general populations. So it's worse than smoking a half a pack of cigarettes a day or being obese to be socially isolated. It is a risk factor in general populations that can affect your risk for heart disease, stroke, cancer, dementia, Alzheimer's disease. In veterans, being lonely is a risk factor for depression, anxiety, suicide, and substance abuse. And loneliness is actually very, very common. And even in the pre-COVID pandemic, there was some surveys that showed that 30 to 40% of elderly patients, just in general, of elderly people in general, reported being lonely. And being lonely in elderly actually puts you at a higher risk of dementia. So we had very little data on looking at the effects of loneliness in general in Parkinson's disease. So I've used two types of words here in giving this talk so far. One is the word social isolation, and then the second is that of loneliness. And so I wanted to take a minute to define these. So what social isolation is the lack of integration of people in their social environment. So I can measure you in your world, who lives with you in your home, who you may interact with. And that's what I can measure social isolation. But loneliness is actually this subjective feeling. It's this emotional state, which I can ask you about, in which you have a felt feeling of being socially isolated. And so really this sort of gap between the relationships that you want and the relationships that you have is really what is this sort of feeling of loneliness. And so in doing this research, I was quite impressed with a few things. So one is that loneliness can be felt in 3 spheres. And flipping it around, you can feel social connection in 3 spheres. And you actually need all 3 of these spheres of connection in order to not feel lonely. And so the first sphere is that of an intimate sort of partner that you have. It might be your wife, your spouse that lives with you at home. And that sort of connects you in this intimate sort of connection. The second sphere is relational. And so you have this longing for close friendships or people outside your home. And so it's important that we all have a friendship circle and not just have a person in our homes that we live with. And then there's this third sphere of connectivity called collective loneliness or collective sort of connection, in which you have a need for a network or community of people that share your sense of purpose. And for some of my veterans, it might be being a veteran. For some Parkinson's patients, it might be being connected to a Parkinson's support group. And for other people, it might be, being interested in a cause or a religious group. So it might be global warming or, being affiliated with the church. So everyone has these need to have these 3 spheres met. And so what I was really fascinated by is that I was thinking that if I was seeing a patient on a virtual visit through a video, and I saw that their wife was there and connected to them, that they were fine, that there was no way that they could be lonely. And actually, I found out through our research that you can still be happily married, and the couple can be lonely together. And so the couple needs to seek relationships outside of just the home sort of relationship with the other person in their home. It's really needing to look outside the home in these other relational and this collective spheres as well. So what is the effects of loneliness on the body? Well, it can affect stress hormones. It can affect immune function. It can affect cognition and make people fixate on negative sorts of things. Like if you are showing people visual images, people who are lonely tend to fixate more on socially threatening stimuli than pleasant ones. And they become hypervigilant, and they can sort of think about the same negative thoughts over and over. It can also disrupt sleep. And so we had this kind of concern about the social withdrawal of many of our people who are living with Parkinson's. Things like reasons include stigma of the disease itself, feeling like they have a number of motor issues as well as non-motor issues that may affect their engagement. And so we have patients who have apathy, depression, anxiety, fatigue, really leading to social withdrawal. And so then we had sort of concerns about what this would look like in our Parkinson's cohorts. A lot of our data stemmed from the pre-pandemic timeframe. So we had an ongoing survey of about 1,700 patients living with Parkinson's in this web-based design. We were surveying people every 6 months with a questionnaire, and we were looking for things that predicted quality of life. And so what we found is that being lonely was a very negative predictor in terms of poor quality of life. It really was one of the main reasons that patients reported a poor quality of life, and having a lot of friends actually boded well for a better quality of life. And something like a motor symptom like tremor, which is a very common problem that many people identify visibly with having Parkinson's, actually did not affect quality of life very much. Additionally, the impact of loneliness was affecting symptoms as well. And we were trying to look for what are some things that people could do in their daily lives, like exercising, that would improve their motor symptoms and non-motor symptoms and their sort of progression of disease. And so what we found in our data set was that exercising 30 minutes a day, 7 days a week, really benefited our cohort. And what we saw is that being lonely was as bad for you in a negative way as the beneficial effects of exercising 30 minutes a day, 7 days a week. And so you can imagine going into the pandemic, we were really concerned about patients who stopped exercising and were socially disconnecting, but thinking about this in a double benefit, not just a double whammy way. There are ways to engage populations of Parkinson's patients, keep them socially connecting as well as exercising. And so I think we've been trying to strategize as to how we can do this. Additionally, when you look at the lonely cohort of patients in our data set, we saw that loneliness was associated with a number of non-motor issues, especially mental health issues. So things like anxiety, depression and motivation, fatigue, all of these things were much more common in patients who were lonely. So this thin blue line, then this sort of shaded blue area, which are the not lonely cohort. And so we really see that the effects of loneliness affect patients more. They affect patients with worse quality of life, worsened motor and non-motor outcomes, but the non-motor outcomes seem to be largely in the mental health arena. And so really, we were really quite concerned about the synergy of 3 pandemics. We have increasing caseloads of Parkinson's worldwide. The loneliness pandemic, I told you 30 to 40% of people who were elderly populations were reporting loneliness before the COVID-19 pandemic, and then enter COVID-19. And really, this was beautifully captured here in this cartoon drawing, where some colleagues in the Netherlands wrote about the concern of social isolation, stress, and physical inactivity, leading to this downward spiral of symptoms and leading to more withdrawal. And what were the sort of possible things that we could intervene with were the things that I felt were important all along: socializing, mindfulness, and online workouts. So really an opportunity to think a little bit more globally about how we can access wellness in these populations. So I wrote a chapter with a colleague, and it's about the effects of isolation in people living with Parkinson's. And we see here Parkinson's cohorts throughout the world, and some larger cohorts. So there's 5,000 patients here that were reported in the pandemic when living with Parkinson's. And in all these cohorts, largely non-motor symptoms and mental health areas increased. So anxiety, depression, apathy, all of these things seem to get worse during the pandemic. And so the concern was not to just talk about doom and gloom and this negative potential of social isolation leading to stress hormone, impaired immunity, worsened sleep, leading to worsened motor and non-motor issues, and then more mental health burden, then leading to more social isolation, but also thinking about how can we intervene. So I want to teach you about something called social prescribing, which is this concept that I, as a doctor, can literally write a prescription for my patient living with Parkinson's who may be isolated to connect with social support in their community. And the National Health Service has had some of this already happening in the UK, where they have this concept of a clinician like me as a doctor referring patients to a link worker through a social prescribing prescription. And then the link worker living in the community, connecting the patient to various types of resources, things like religious, spiritual organizations, things like exercising, other sorts of things that are happening in the community. And so at the VA, we had a similar sort of intervention where volunteers that used to come into the VA were redeployed to call on patients who were lonely throughout the VA, lonely veterans who could be identified and referred to this program. And so through a weekly phone call or video visit, these volunteers were able to connect in this proactive way. So we described this in this New York Times article. I also did a TEDx talk about this. And so we've been talking to whoever will listen to us really about this concept of social prescribing. And I don't just talk this talk, but really I've been walking this walk since day one of the pandemic. I've been partnering with a support group that is online called the PMD Alliance. They're based here in Arizona. And we've been talking to and interviewing a number of thought leaders. We have about 110 of these interviews now, and we've been doing this live through this virtual modality. We do about one a month, but at the most we were doing one a week during the height of the pandemic, and really trying to connect our patients throughout the world, really, through this virtual support group. I've also been blogging on this parkinsonsecrets.com blog with Dr. Oken, and really trying to get clinicians to think about getting patients to leave their homes every day, because this, in some follow-up data, has shown to be beneficial in terms of engaging patients and improving loneliness scores. Even with daily phone or video modality, trying to get people to connect in these ways, if they can, even to be volunteers, if they're doing better with social connection and you're living with Parkinson's, maybe finding 5 people in a support group that you might be able to contact who are a little bit more isolated, finding people in your lives to be your cheerleader, confidant, your tribe, connecting through these virtual modalities through to support groups, exercise classes, and religious groups, maybe using Zoom technology or FaceTime to connect with your family. And as I mentioned, I have not just been talking this talk, but really walking this walk. This is my family. My parents live in Canada. My sisters live with their families in the Bay Area as well as in Colorado. And we've been weekly doing these Zoom meetings for the last 2 years, really connecting my children and their cousins, connecting me to my sisters and my parents. And it's really been a lifesaver. So we've tried to figure out what we can do to screen populations. And so the question that we find most effective is, do you sometimes or often feel left out? So we're trying to teach clinicians about asking this question proactively. So again, that's, do you sometimes or often feel left out? Do you sometimes feel isolated from others? This is a subset of the UCLA loneliness questionnaire. Think about engaging patients and connecting them through social prescribing. Think about other psychological interventions, and also helping patients to create wellness strategies in their daily lives. And so we're really giving this talk. This is a talk I just gave at the Movement Disorder Society Pan American section, and it was very well received. And so the concept that we can engage patients and educate them to try to help them understand about their disease, to understand more about mental health and how important it is through the trajectory of their disease, help teach them lifestyle choices that can empower them every day to choose some of these choices, including social engagement, diet, sleep, exercise, the mind-body approaches. Think about realigning the healthcare team and bringing it back into the community, and not just in my office where I'm wearing a white coat and you come and see me once in 6 months and I tweak your Parkinson's medicine, but really thinking about who else we can engage in a multidisciplinary team approach, maybe the physical therapist, maybe the psychologist, maybe the social worker, maybe a yoga teacher, maybe a religious leader. Think about who all touches the patient in your own lives. And then how can we then help you as the person living with the disease feel like you're part of who is driving the bus. So when we think about that sort of out of the box social connection, many of our patients have proposed their own sort of solutions. And so there are a number of online groups offering things like peer-to-peer mentoring. This is my patient, Twitchy Woman, who runs a virtual online support program for women living with Parkinson's worldwide now. This is Ben Stetcher. He had proposed a mental health check-in buddy, a friend that you might be able to connect with once a week to check in about your mental health. Think about engaging, as I mentioned, allied health professionals or multidisciplinary team approaches. In the VA, we have these health coaches. The Michael J. Fox Foundation has this buddy network. So really thinking out of the box. And so just putting in one or two last slides here, a couple of plugs. So the caregivers that are out there, we see you, we realize that you've been working tirelessly to help your loved ones. So really emphasizing that oxygen mask analogy of putting on your oxygen mask, taking care of yourself before you can take care of anyone else, getting adequate sleep and rest, and thinking about just all the emotions that all of us have really been dealing with from day one of the diagnosis. And this has been not just a sprint, but really a marathon. And so I think finding ways to really take care of ourselves. And so a couple of last resources. So I love this book, Together, by Dr. Murthy, Vivek Murthy, who is the current Surgeon General. He writes a lot about the space of social connection and loneliness. Viktor Frankl's work has been amazing. I urge you to read this book if it's available to you. And so really this concept that we have this wellness prescription in which I, as a clinician, can meet you from day one of diagnosis and give you a sense that you are in control of the outcomes of the lifestyle choices that you make every day, that you feel like you have control in your disease state and its outcomes, provide you with ways to know that you need social support and to get that social support in your community, help you create structure in your day, to help you drizzle in some exercise, to drizzle in healthy lifestyle choices like good sleep, social connection, things like that, mind-body approaches. Help you get things that are accessible to you. So it doesn't help if my wellness prescription only includes going to a gym in a metropolitan center and needing to get on a treadmill every day for 30 minutes. This is not acceptable or accessible to many people living with Parkinson's. So how can I help you find ways in your own life that tick the boxes that I showed you in that wellness prescription? And we understand that many populations are not interested in pharmacological or device approaches. And so we really have to think outside of the box of those when we're giving these sort of talks to our patients who have, maybe living in other geographical arenas, maybe culturally very different. And so I want to thank you for the opportunity to give you this talk to the patients who really continue to inspire me every day. Urge you to find out about folks like the PD Avengers, which is this group of patients that started this group. They are themselves advocating around a lot of these issues. And urge you to also possibly read the book Ending Parkinson's Disease, which has a lot of important information around advocacy that includes some of these patient sort of focused advocacy around getting involved in research and clinical trials, helping other patients around the world get the care they need. So really, I think there's a lot of great energy in a lot of this arena right now. So thank you again for the opportunity to speak to you. Happy to take questions. And thank you, Dr. Evidente and the rest of the team here for making this available.